me. Good morning, and thank you for having me. This should take about 5 minutes because I feel like I'm just going to turn the elephant around a little bit and talk about the policy side of everything that Dean already talked about. So thank you for having me. Oops, is that up? Thank you. Awesome. Here we go. All right, so my name is Meg Booth. I'm the Executive Director of the Children's Dental Health Project. We're a nonprofit organization here in DC, but we're really based on the no family should be held back from their dreams because of dental disease. We work each and every day to advance innovative policy solutions so that systems changes can remove oral health as a driver of inequities. And we do this through 3 major domains in the interest of families, really to integrate oral health into existing systems where families live, learn, and work. We also remove race, income, and geography as drivers of oral health, and really are trying to make health and quality of life the metrics for oral health care instead of disease burden right now. We play a unique role in oral health as a consumer advocates. We represent the interest of families, not any other part of the industry. And in doing so, we worked and we continually seek to find ways that drive oral health policy, specifically with policymakers at the state, federal level. After significant gains in oral health coverage, really looking at 90% of kids having coverage now, that there's still the interest among policymakers, more interest among policymakers on looking at utilization and dental visits among the population, we really had to take a step back and look at how difficult it is to make the case that policymakers should address oral health, and really that disease burden isn't top priority right now in policymakers' minds. So we began examining the information that we were providing to policymakers. We really wanted to engage them on incentives to drive health that include oral health. But historically, we had been focusing on the prevalence of disease and not really focusing on how that impacted the lives of their constituents. So we started to ask ourselves, what is it that they really want to know, right? If we found ourselves asking policymakers to fix a broken system that included dental care for low-wage families, we realized that it didn't really address the issues that we were talking about. So in 2017, we hosted a national focus group of influential community leaders, including pediatricians and state legislators, state advocates, and hospital administrators to talk to us about oral health. What we learned is there's a basic lack of oral health literacy amongst community, not only community policymakers, but those that are influencing policymakers. And not only about the disease burden, but the impact that it has on their community. So in 2018, we decided to dig a little bit deeper. We traveled to Texas and to Maine to 4 different communities to talk to their influential policymakers. And these were participants that ranged from educators to business owners, retired medical professionals, but all had contact 5 times, at least 5 times in the last 12 months with a policymaker at a local, state, or federal level. So really looking at those people that have tried to make the case to a policymaker at some time in the last year. And here's what we learned from them. So when we asked them about overlooked issues in their community without introducing them to oral health, we asked them if they could name what the overlooked issues are. None of them ever named oral health. However, when you brought up oral health, they quickly said, oh yeah, that is a priority for us, but the fact that we didn't name it tells you how overlooked it really is. There was also a general sense that walking into a dental office sort of took care of the problem, and it didn't really require much consideration outside the office because they didn't really understand that dental caries, which is primarily what we were talking about, is actually a disease. However, on the other hand, when you talk to them about oral health, there was a clear, consistent frustration that dental was separate from the medical system, both on coverage and payment and sort of where the care was delivered. And as you'll see in sort of comments that they make, there's an overwhelming recommendation, similar to what Dean was saying, is to move towards the consequences of the disease and less about the prevalence. So here's what some of them had to say. So when we asked them generally what they had to say and what they were surprised to hear is that they were that most policymakers are not aware. They just don't understand that it's a chronic disease and it needs to be treated on an ongoing basis. Somebody else said we need to make the case better that oral health is better about not only oral health, but the cost to society of oral health. And then this one will sort of defeat a lot of people that are in the room that have been working on this a long time, but I don't think dental care is often talked about as a chronic disease. I mean, that's a very strong word. I think for those of us that are in this space and have been for a while, we feel like we've been giving these messages, but it's not resonating down to a community level. So when we asked participants then to sort of, we laid out a couple of standard messages that I think many of us that work in oral health know, sort of about the ability of risk-based care, sort of looking at assessing kids for risk of dental disease, looking at job creation and sort of employment figures, and military readiness. Here are some of the things they had to say. Isn't prevention always the best tool? How many times do we have to learn that lesson? State legislators talk a lot about job creation. So if you were to say these guys can't get a job because their teeth, it's holding them back, that's going to make a big difference. And then there's the surprise that, are we really not sending troops over? You know, is that really true about deployment? Like, wow, that's powerful. So this is going to go quick. So this is almost exactly what Dean has in his slides. It's about the consequences. So after 20 years of our organization really telling policymakers that oral health is important, we started looking at the messages that we were getting from the field and really beginning to use the research to sort of flip the script and really talk about the impact that oral health has on the goals of policymakers. So we started looking in these domains, really, the social function, education, economic mobility, employment, and overall health that seem to come up, whether you look at polling of why people vote, what we hear about from Capitol Hill or state legislators. I think similar to the information that Dean provided, we looked at sort of the separateness of sort of the dental system and sort of and the payment system that really restricts our ability to look at the impact and the incentives for oral health and primary care. For example, we know that 80% of kids in Medicaid, ages 1 and 2, get a well child visit, but only 20% get a dental visit for preventive services. At the same time, for fluoride varnish, we know that it's reimbursed by Medicaid programs in every state at this point. However, only 10% of kids in the Medicaid program that are ages 1 and 2 get any type of preventive service from a non-dental professional. So we're really sort of hamstringing ourselves on where that integration is. And I think it's important to sort of take that into account when we think about what the role is in a primary care setting, is that there are policies in place right now that support that work. Really looking at, especially when it comes to Medicaid, that there are guidelines now that talk about assessing children for risk, and there's in some places payment that can be had. However, it's not really translated and it's not always reimbursed in every state. So if we're looking at sort of the impact, sorry, I didn't move my slide. These are the things that are sort of holding us back, is sort of the rigidity on the dental care system and where we're really creating those incentives to integrate with primary care. Sorry, I'm not good at my slides.
The slide before was worth going over. I think you skipped over it. The one before.
How do I go back?
I know. Can you go back 2 slides? That one.
Yeah.
You didn't really go through it.
I think these are a lot of things that you talked about. So.
No, they're different.
So these are some of the things that we really looked at, is really looking at the bidirectional research on oral health and some of the key areas, like mental health, that research shows that oral health can impact individuals, primarily adolescents and older Americans, when it comes to the confidence and their mental health status. The same with working mothers, the statistic that Dean just said, that women are disproportionately impacted by oral health. The fluoridation issue really shows that women earn 4.5% higher when they have good oral health. And if you take that into consideration, that more than half of women are the sole or primary breadwinners of their families, somewhere between 67% for all mothers and into the 70% for African American women who are the sole or primary breadwinners, really looking at the impact long-term that has on families. Similar For education, immediate education impact on children that are sitting in a classroom in pain, but also looking longer term at the consequences of education among kids that suffer with significant dental disease on opportunities for employment also. And also in healthcare, I think it's been talked about a lot, the comorbidities of oral health and diabetes and pneumonia in older adults, and the quality of life issues that happen there, or the long-term health costs that happen in both those populations. So I think it's clear that some of the low-hanging fruit are really the clinical integration issues, which I think goes to the pyramid of talking about where we can have an intervention, specifically when it comes to kids and their parents, which is the primary audience that we look at, are looking at oral health risk assessment and the care coordination that can provide, and really the benefit design that allows that to happen. And when we need restorative care, it can happen outside that primary care setting, but there are huge opportunities that really are being put in place in some places, but not on a systems-wide level. I think the more daunting task is the integration at the systems level when it comes to how do we pay for these things on an outcomes, how do we pay for health outcomes, value-based purchasing, and the ability to do both through electronic health records. Without the ability to really track across the systems, we're always going to have an uphill battle, which I think has been discussed today also. So as we engage policymakers from the community to Congress, we understand the impact of oral health on their priorities, and the barriers quickly become overwhelming for many policymakers if we're not able to lay a clear path for where they can have interventions. As we're looking at re-examining consequences, I'm encouraging all of us to think about how to build oral health literacy within a larger context, and in conversations where we can still offer some of our partners those interventions, especially at a local level where families live, learn, and play. As the conversation continues today, I also challenge us to think even broader of integrating into beyond looking into primary care, and given the impact of poor oral health that it has on individuals, families, community, and our economy. Oral health is really intended to be a means to health and opportunity and not an endpoint. And I think we need to focus on how we might bring oral health into systems and touch points that exist for families and children beyond just the clinical settings, whether it's early childhood education, social programs, job readiness programs, but really take the time to talk to partners outside of our healthcare system to make a broader system for change. So I'm happy to answer any questions, but I'm really here to learn more from people that are doing this work on the ground and the research to figure out ways that we can really support families to reach their dreams.